Hello, and welcome to the ASCO Daily News Podcast. I'm your host, Dr. John Sweetenham, and I'm delighted to be joined today by Dr. Erika Hamilton, a medical oncologist and director of breast cancer and gynecologic cancer research at the Sarah Cannon Research Institute in Nashville, Tennessee. Dr. Hamilton is also the chair of the 2025 ASCO Annual Meeting scientific program, and she's here to tell us about some of the key abstracts, hot topics, and novel approaches in cancer care that will be featured at this year's annual meeting. Our full disclosures are available in the transcript of this episode. Dr. Hamilton, it is great to have you on the podcast today, and thanks so much for being here.
Thanks, Dr. Sweetenham. I'm glad to be here.
So, Dr. Hamilton, the presidential theme of the annual meeting this year is driving knowledge to action, building a better future. And that's reflected in many of the sessions that will focus on action-oriented guidance to improve care for our patients. And as always, there'll be great presentations on practice-changing abstracts that will change treatment paradigms and transform care. Can you tell us about some of the hot topics this year and what you're particularly excited about?
I would love to share. You're right. Dr. Robinzon's theme is driving knowledge to action, building a better future. And you're going to see that theme really interlaced throughout the ASCO program this year. We had a record number of submissions. Over 5,000 abstracts will be published, and there'll be about 3,000 presentations, either in oral format or poster presentations. We have 200 dynamic sessions. Many of the discussants will be highlighting key takeaways and how we can translate action-oriented guidance to better treat our patients to build a better future. Our state-of-the-art science will include a plenary session. This will feature presentation as well as discussion of each of the presentations for clinical late-breaking abstracts as well. We have clinical science symposia that I'm particularly excited about this year. These will be featuring key abstracts as well as discussants and a foundational talk around the subject. We're covering novel antibody-drug conjugate targets, turning cold tumors hot to include CAR-T, as well as the future of cancer detection. There'll be rapid oral abstracts, case-based panels, and this will also feature interactive audience polling and case discussions. I also want to highlight the community connection opportunities. There'll be 13 communities of practice that will be meeting on site during ASCO. And there's also really a plethora of network opportunities for early career professionals, women networking center, a trainee lounge, a patient advocate space. And I'm happy to report there will also be live music out on the terrace this year at ASCO.
Well, that's going to be a really great addition. I have to say, I think this is always a special time of year because excitement starts to mount as the meeting gets closer and closer. And once the abstracts are out there, I certainly personally feel that the excitement builds. Talking of abstracts, let's dive into some of the key abstracts for this year's meeting. I'd like to start out by asking you about abstract number 505. This reports on 15-year outcomes for women with premenopausal hormone receptor positive early breast cancer in the SOFT and TEX trials. It assesses the benefits from adjuvant exemestane and ovarian function suppression, or tamoxifen and ovarian function suppression. So could you talk us through this and tell us what you think the key takeaways from this abstract are?
Absolutely. This is essentially the SOFT and TEX trials are trials that we've been following for quite some time, evidenced by the 15-year outcome. And I think it really answers two very important questions for us regarding adjuvant endocrine therapy for patients that are facing hormone receptor positive disease. The benefit of ovarian function suppression, for one, and then second, the benefit of exemestane over tamoxifen, which is our SERM. So in terms of the SOFT trial, when we talk about distance recurrence-free interval, which I really think is probably the most meaningful because secondary cancers, et cetera, are not really what we're getting at here. But in terms of distant recurrence-free interval, certainly with tamoxifen, using tamoxifen plus ovarian function suppression adds a little bit. But where we really get additional benefits are by moving to exemestane, an aromatase inhibitor with the ovarian function suppression. So for example, in SOFT for distant recurrence-free interval for patients that had received prior chemotherapy, the distance recurrence-free interval was 73.5% with tamoxifen, bumped up just a tiny bit to 73.8% with ovarian function suppression. But when we used both ovarian function suppression and switched to that aromatase inhibitor, we're now talking about 77.6. It may seem like these are small numbers, but when we talk about an absolute benefit of 4%, these are the type of decisions that we decide whether to offer chemotherapy based on. So really just optimizing endocrine therapy really can provide additional benefits for these patients. Just briefly, when we turn to text, similarly, when we look at distance recurrence-free interval for our patients that are at highest risk and received chemotherapy, tamoxifen and ovarian function suppression, 79%, 81% with exemestane and ovarian function suppression. And when we talk about our patients that did not receive chemotherapy, it increased from 91.6 up to 94.6. So that very similar 3 to 4% number. So I think that this is just very important information when counseling our patients about the decisions that they're going to make for themselves in the adjuvant setting and how much we want to optimize endocrine therapy.
Thanks so much for your insights into that.
Yeah, absolutely. So let's turn to hematologic malignancies. Abstract 6506 reports exciting results on the new agent ziftomenib in relapsed refractory NPM1 mutant acute myeloid leukemia. This is a phase 1b clinical activity study and safety results. This was the pivotal COMET-001 study. And my question is will this new agent fulfill an unmet need in this NPM1 space?
Yeah, great question. And I think the answer is almost certainly yes. So, just as some brief background, NPM1 mutation is known to be a driver of leukemogenesis in around 30% of patients with AML and is a poor prognostic factor. And typically, about 50% of these patients will relapse within a year of their first line therapy, and only around 10% of them will get a subsequent complete remission with salvage therapy. Menin inhibitors, which disrupt the interaction between menin and KMT2A, are known to be active in NPM1 mutated as well as in KMT2A rearranged AML. And ziftomenib is a selective oral menin inhibitor, which in this study was evaluated at a dose of 600 milligrams once a day, as you mentioned, a phase 1b/2 study, which is multi-center and presented by Dr. Eunice Wang from Roswell Park. It's a relatively large study of 112 patients who were treated with this standard dose with relatively short median follow-up at this time. The median age was 69 years and median prior therapies were 2, but with a range of 1 to 7. And I think very importantly, 60% of these patients had previously been treated with venetoclax and 23% of them had had a prior transplant. Looking at the results overall for this study, the overall response rate was 35%, which is actually quite impressive. Specifically for those patients in the phase 2 part of the study, around 23% achieved a CR or CRh. What's very interesting in my mind is that the response rates were comparable in venetoclax naive and venetoclax exposed patients. And the drug was very well tolerated, with only 3% of patients having to discontinue because of treatment-related adverse events. And I think the authors appropriately conclude that, first of all, the phase 2 primary endpoint in this study was met, and that ziftomenib achieved deep and durable responses in relapsed and refractory NPM1 mutated AML, regardless of prior venetoclax, with good tolerance of the drug. And so I think putting all of this together, undoubtedly these data do support the potential use of this agent as monotherapy and as a new option for those patients who have relapsed or refractory NPM1 mutated acute myeloid leukemia. So let's move on a little bit more now and change the subject and change gears completely and talk about circulating tumor DNA. This has been a hot topic over a number of years now. And at this year's meeting, there are quite a few impactful studies on the use of ctDNA. We have time to focus on just one of these, and I wanted to get your thoughts on abstract number 4503. This is from the Niagara trial, which looks at ctDNA in patients with muscle-invasive bladder cancer who received perioperative durvalumab. Could you tell us a little bit about this study?
So this was the phase 3 Niagara trial, and this is literally looking for patients with muscle invasive bladder cancer that are cisplatin eligible, and the addition of durvalumab to neoadjuvant chemotherapy. So here, this is a planned exploratory analysis of ctDNA and the association with clinical outcomes from Niagara. So this is really the type of study that helps us determine which of our patients are more likely to have a good outcome and which of our patients are more likely not to. There were 1,000 randomized patients in this study, and 462 comprised the biomarker evaluable population. There were about half in the control arm and half in the durvalumab arm. And overall, the ctDNA positive rate at baseline was about 57%, or a little over half, and that had decreased to about 22% after neoadjuvant treatment. ctDNA clearance rates from baseline to pre-radical cystectomy was about 41% among those with durvalumab and 31% among those in control. And the non-PCR rate was 97% among patients with pre-cystectomy ctDNA positive status. So this really gives us some information about predicting who is going to have better outcomes here. We did see a disease-free survival benefit with perioperative durvalumab, and this was observed in post-cystectomy ctDNA positive as well as the ctDNA negative groups. Shifting gears now to GI cancer, Abstract 3506 is a long-term safety and efficacy study of sotorasib plus panitumumab and FOLFIRI for previously treated KRAS G12C mutated metastatic colorectal cancer. And this is the CodeBreak 101 study. What are your thoughts on this study?
Yeah, thanks. A very interesting study. And this abstract builds upon the phase 3 CodeBreak 300 trial, which I think has just been published in the Journal of Clinical Oncology. This showed that the combination of sotorasib and panitumumab improved clinical outcomes in patients with chemo-refractory KRAS G12C mutated metastatic colorectal cancer. The current abstract, as you mentioned, reports the CodeBreak 101 trial, and this was a phase 1b trial where FOLFIRI therapy was added to sotorasib and panitumumab in previously treated patients with KRAS G12C mutated metastatic colorectal cancer. The abstract reports the overall and progression-free survival results, as well as some updated safety and response data. So in this study, patients with this particular mutation who had received at least one prior systemic treatment, but were KRAS G12C inhibitor naive, were enrolled into an expansion cohort of the CodeBreak 101 protocol. And these patients received a fairly now what's recommended as the standard phase 2 dose of sotorasib of 960 milligrams daily, plus panitumumab, and a standard dose of FOLFIRI. And the primary endpoint of the study was safety, and secondary endpoints included confirmed response, overall response, and progression-free survival as assessed by investigator. And by November of last year, 40 patients had been enrolled into this study. Common treatment-related adverse events were cutaneous. Some patients developed neutropenia, and stomatitis was fairly widespread. Discontinuation of sotorasib because of adverse events was only seen in 1% of patients, although patients did have to discontinue because of toxicity from some of the other agents in the combination. Looking at the results of this study, the updated objective response rate was 57.5%, and the disease control rate was estimated at 92 going on 93%, with a median time to response of 1.6 months and a median response duration of 6 months. After a median follow-up of 29.2 months, the median progression-free survival was 8.2 months, and the overall survival 17.9 months. So the authors have concluded that this combination, including sotorasib, panitumumab, and FOLFIRI, does appear to show quite promising long-term efficacy in pre-treated patients with this specific mutation. The ongoing phase 3 study they mentioned, CodeBreak 301, is aiming to evaluate this combination against the standard of care in the first-line setting for patients with KRAS G12C mutated colorectal cancer. So promising results, and we'd be very interested to see how this particular combination performs in the front line.
Fantastic. Thanks so much for sharing that. Let's shift gears again and really talk about digital technology. I feel that we're all going to have to get much better with this. And really, there are a lot of promises for our patients coming here. There are a lot of abstracts at ASCO that are focusing on innovations in digital technology, including a really interesting psychosocial digital application for caregivers of patients that are undergoing hematopoietic stem cell transplantation. Can you tell us a little bit about this? It's abstract 11000.
Yeah, absolutely. Yeah, this abstract certainly caught my eye, and I think it's intriguing for a number of reasons. Partly because it's app based, and partly also because it specifically addresses caregiver burden and caregiver needs in the oncology setting, which I think is especially important. And although the context, the clinical context of this study is hematopoietic stem cell transplantation, I think it has potential applications way beyond that. We all know that caregivers of patients undergoing stem cell transplantation have significant quality of life struggles. They have well documented to have significant psychological and emotional strain before, during, and after stem cell transplantation. And this abstract describes an application called BMT Care, which is aimed at improving caregivers' quality of life, caregiver burden, mood symptoms, and coping skills, and so on. So this was a single center randomized trial from MGH of this app for stem cell transplant caregivers compared with usual care in those individuals. And the eligible patients or eligible individuals were adults caring for patients with heme malignancy undergoing either an autologous or an allogeneic stem cell transplant. Patients were randomly assigned either to use the app or for usual care. And the app itself, and I think it'll be interesting to actually see this at the meeting and visualize it and see how user friendly and so on it is. But it comprises 5 modules which integrate psychoeducation, behavior change, stress management, and they're delivered through a kind of interactive platform of educational games and videos. And then participants were self-reporting at baseline and then 60 days after transplant. So around 125 patients were enrolled in this study of around 174 who were initially approached. So just over 70% uptake from caregivers, which is, I think, relatively high and evenly distributed between the two randomized arms. And the majority of the participants were spouses. And at 60 days post stem cell transplant, the intervention participants reported a better quality of life compared with those who received usual care. If you break this down a little bit more, these participants reported lower caregiving burden, lower incidence of depression, fewer PTSD symptoms, and overall better coping skills. So the authors conclude that this particular app, a digital health intervention, led to pretty substantial improvements in quality of life for these caregivers. So intriguing. As I said, I'll be particularly interested to see how this thing looks during the meeting. But if these kind of results can reproduce, I think this sort of application has potential uses way beyond the stem cell transplant setting.
Yeah, I find that just so fascinating and very needed. I think that the caregiving role is often underestimated in how important that is for the patient and the whole family. And really giving our caregivers more tools in their toolbox certainly is quite helpful.
Absolutely. Well, the meeting is getting closer. And as I mentioned earlier, I think anticipation is mounting. And I wanted to say thanks so much to you for chatting with me today about some of the interesting advances in oncology that we're going to see at this year's meeting. There is a great deal more to come. Our listeners can access links to the studies we've discussed today in the transcripts of this episode. I'm also looking forward, Dr. Hamilton, to having you back on the podcast after the annual meeting to dive into some of the late breaking abstracts and some of the other key science that's captured the headlines this year. So thanks once again for joining me today.
Thanks so much for having me. Pleasure.
And thank you to our listeners for joining us today. Be sure to catch my top takeaways from ASCO 25. These are short episodes that will drop each day of the meeting at 5:30 p.m. Eastern Time. So subscribe to the ASCO Daily News Podcast wherever you prefer to listen and join me for concise analyses of the meeting's key abstracts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.